Hello and welcome to webinar series. Myself Shanti, and today's topic for discussion is all about near miss errors. As we all know, near miss is not much spoken or seen, and awareness on the same is very low. So now I request the speaker on the panel to introduce themselves. Yeah, I request Danishta now. Danishta, over to you.
Good. Thank you, Shanti Bhattacharya, for a wonderful opportunity to making an awareness on near miss errors and causes and prevention. Myself, Danishta, and Chief Operating Officer for Nagarjuna Hospitals, Vijayawada, and I'm a National Health Mission Assessor and Ayushman Bharat Assessor, and WHO Patient Safety Surveyor and KAHO Governing Board member. Thank you.
Yes, over to you, Sumani.
Good afternoon, everyone. Welcome you all to the webinar. Thank you, Shanti, for giving this opportunity to interact with the team on a very important topic close to our daily work. Coming to me, I am heading nursing services for Fernandez Hospital. And over to you, Shanti.
Thank you so much, and it is our privilege, and we are honored to have you both, in this discussion today. I welcome you both, and yes, as Danishta and you mentioned as well, like near misses, daily term which we get to see, but the awareness is not seen much. Yes. So, firstly, we like to understand as Danishta is expertise in quality management, pattern. Like, what is near miss in a bedside scenario? I think yes, every nurse, every medicos, everybody experiences this near miss, error. So what is this about? Yes, over to you, Dhanishta.
Near miss is an event that potential to do harm, but it didn't reach to the patient. An error caught before reaching to the patient. It could be an error or injury, it may happen. So there is a National Safety Council has given a clear definition also. A near miss is an unplanned event that even did not result in injury or illness or damage, but it has a potential to do.
Yes.
It basically
Here,
didn't reach the patient.
yes. Here, you would like to give one example, like maybe the nurse was ready to give 60 mg of Lasix, but the order was only 40 mg of Lasix. But suddenly she realized, or somebody, tried to recheck with what she was loading and going to the patient bedside, or patient must have just, told or, realized, yes. Because nowadays all patients are very educated, they know, they take care, in the decision making process. Yes, very rightly said. It has not caused any injury or damage to the patient. Yes. Going forward, like yes, so many we like to even understand like these nurses we have in our hospitals, even medicos or clinicians understand that a near miss is something related to an error. Firstly, do they identify that this was an error which they were trying to introduce to the patient? Yes, over to you.
Yes, many nurses associate near misses with errors, especially medication and handover errors, but they underreport it. Junior nurses often hesitate to report near misses because they fear it may be treated as a mistake. Doctors usually recognize near misses as potential errors avoided, especially in diagnosis and prescription. However, many of them do not recognize it as an error because it is not harm the patient.
Yes.
Allied health staff, OT technician, lab technician, and other physiotherapists may not link near misses with error. They often understand it as a safety incident that was prevented, but without formal training, they may not classify it as an error that did not reach the patient. However,
Yes.
many of the thing near miss is almost accident. It is a warning sign of lapses in the system.
Yes. Yeah, as rightly you said, they may fail to identify and they may think this is one could be, one safety incident which has taken place. Yes. I also like to understand from Dhanishta, what do you think? If at all you think this near misses, if they report every day, you might not have a place where you can just keep, loading all these incident forms. Do you think near misses are reported?
Near misses has to report it. The reason it is a first step of learning from the event. If we
Yes.
don't learn from the event, so that keep on occurring, one fine day, this near miss will become a sentinel event.
Yes.
And most of the time, nurses not aware that is a near miss.
Yes.
Immediately it got strike, they have overloaded. Okay, they do the right thing, then they forgot the thing. At least such kind of thing, the potential risk they have to maintain ward wise, risk register to be maintained. One time eh, if incident report is not raised, at least they have to jot it down. What are the situations, what are the uh, which are the timing, maybe night time or early morning or
Yeah.
afternoon, what time is
Yes.
potential to go for a near miss, that ward wise risk register can be maintained to proactively to prevent the incident or near miss in the ward.
Yes. So again, we like to, we all three understand here that near misses are not, reported unless until, it has caused the direct injury or threat to the patient. Yes. So again, we like to have your insight on the, is near miss an incident? Like near incidents are incidents. Now, many of the nurses, they know, yes, something has gone wrong with the patient or in the system or in the, maybe they were trying to raise the medication indent. But from the pharmacy, we got the low dose or high dose for the same. So, is near miss is an incident, Danishta?
If that causing harm to the patient, then it became an incident. If
Yes.
that is not resulting any harm or injury, then it became a near miss.
So,
Near
for,
miss doesn't
yes. Yeah,
injure
please.
the patient. A best real example, a twin sharing room, two patients, same surgical patient, same post-operative patient, one patient having diabetic, one patient doesn't have. Most of the nurses overloaded with work. So instead of giving to the one patient, either she gone to shift to another patient, either she went to theater to receive other patient. Other nurse has loaded insulin and she instead of giving A bed, and she might give to a B bed. So these all incident. The other nurse will come and realize, okay, this drug is not for the A bed and this has to given to B bed.
Yes.
So this is one kind of example. If side rails is not placed, patient went to a toilet and come back and safely lie down. That also a near miss without any attendant, post-operative patient, and if he's gone, with such kind of things has to be recorded. Each ward wise, each ward having a risk, maintaining a risk register and doing a RCA, which will prevent incidents and near miss.
Yes, yes. As you rightly gave a few examples, yes. Uh, I mean to say, like daily not following the IPSG goal also will risk the patient's safety. Yes, like yes, we try to understand here with so many. Like, what are the few common causes you get to witness in a form of real miss whenever you have your NQI meetings or you have your meetings with the qualities, whenever you sit for the analyzation of the patient safety event? Yes, Sumit, over to you.
The
What are the few
first
causes?
cause for the near miss is communication gaps, unclear instructions, where they might have either misheard it or misinterpret the verbal physician orders, not clear
Yes.
about the abbreviations, or failing to inform the next shift about the patient condition or a medication order, or delayed escalation or of a deteriorating patient condition due to hesitation or lack of assertive communication. The
Yes.
second place is handover errors or protocols. Incomplete handover, where most important patient details like allergies, either lab values that are omitted but discovered later, and then
Yes.
wrong patient handover, like a lab report of one patient, patient A is handed over to patient B, and
Yes.
failure to highlight critical issues during the shift. And
Yes.
lastly, the insufficient competency, lack of necessary skills, not able to follow the orders because of the inadequate knowledge of the nurses, and also new nurse administering a medication in a wrong site, where an IV injection should is she's trying to administer an IM, and the new senior nurse comes and teaches that, and
She gets to witness.
inadequate knowledge of infusion
Yes.
settings. So these are the three major categories where they fail, and they
Do error.
yes,
Yes. Yes.
identify
As
as near
rightly.
miss.
Yes, as you said rightly, these are the few causes. Yeah, we try to quote only few. There are many causes, but yes, yeah. So yeah, how near miss should be mitigated or mobilized, Dhanishta, as per your insight. Yeah.
I'm experienced as a nursing expert with so many as a vast experience. I've addressed most of the points, 3 points. But however, I come across with my quality journey over 15 years. I noted some of the thing while recruiting itself, nursing leaders thoroughly interview and questions, and they after skills only they will be posted in the particular ward or
Yes.
theater or where the workplace is. But what I keenly noticed, and there is a recently I gone through the international journal, which is IHI, consciousness and unmindfulness. This is the most common cause of near miss and events. So
Yes.
this event, there are some nurses, they always doing correct thing and every time. That is called
Yes.
safety one. There is safety
Yes.
two. So they go for flip, sometime error. So the reason is most common reason unmindfulness and consciousness what they are doing. Sometimes overloaded also. One nurse, suddenly the other nurses didn't come, that burden with the 10 other patients have to be take care by the one patient. And
Yes.
especially they go for all time, single time for a lunch, or they all engage for one activity. So 2 to 3 everyday nursing sessions, training session, all will go for training. So such kind of thing which we can mitigate the risk and more vigilant. Supervisors has to teach their young nurses. Nowadays most of the supervisors, I can see the tiny the small nurses, the freshers also becoming a what supervisors. And because they are having a master degree, so they are becoming a
Yes.
higher hierarchically higher grade. So what all they have a skill, they have to more vigilant, especially patient safety rounds, which is known as in Japanese gamba walks, real time into
Yes.
real place. Gambas the word it derived from. They have to see in the right place, and they have to correct it then and there. And if there is any near misses which occurs, that has to be educated. And each ward supervisor, they have to be more vigilant, not to be punitive. They have to
Yes.
learn from activities which can bring down the errors.
Yes. So I think we request
And
all the
culture, promoting a culture,
yes, promoting a culture. Yes. Please continue. Yes, Dhanishta. You were trying to say promoting a safe culture?
yeah, reporting culture, there, yes, safety culture with reporting culture and learning culture. And just culture also is most important thing. If someone is doing wrong thing first time and every time, we have to eliminate them from the system. If it is violation of the policies or continuously if they are wantedly doing, that is called just culture, that has to be eliminated.
Yes. Yes, I think we all will agree with this point that high detailed rounds will solve and sort lot of your issues. This is how we expect all the nurses, seniors, in charges, and even in the freshers. If at all the high detail rounds observations are proper, I think more majority of the errors will be prevented. Yes, yeah. Going forward, as what are few proactive risk management a nurse in charge or shift senior can do to prevent a near miss? Because this is very important nowadays. Every patient has got their own complex scenarios they come to the hospital with. Yes, over to you, Suman.
Uh, from the starting of the nursing studies, nurses are trained on nursing process steps, nursing
Yes,
assessment, planning, implementing, and evaluation. So, assessment, which is simply observation, is the first
yes,
mode uh, step of the proactive risk assessment. Charges should do risk assessment and identify potential causes of the risk. Example, they can train nurses how to observe a patient and how to identify complications. Example, if you see in this picture, a nurse who has observed a patient is at risk of developing DVT, deep vein thrombosis. She has to inform to the doctor about the risk of DVT, and then the doctor can advise either antiembolism, stocking, or the medication which prevent further complications. In
Yes.
charges have to closely work with the nurses and the team to mitigate such measures, and based upon the incidents or the learnings, the protocols should be developed or revisited, updated, and a thorough training should happen. Whatever new initiatives you are doing, it should reach to the nurses who are practically working, and then continuous quality improvement. So this is the cycle that should be involved for proactive risk management.
Yes. Few very key parameters you have mentioned. Yes, I appreciate for that. Yes. And yes, over to you, Danishna. Again, when to raise an incident for such a near miss scenario? Like when nurse should raise the incident.
Immediately after near miss, incident has to be raised. Don't
Yes.
fear of a guys, a furious nursing in charge were showing in the picture. Despite you have to raise an incident, you need not to
Yes.
suffer or you need not to fear by seeing your superior or in charge whom you are going to report, because it may potential to do harm. So despite if there is no injury or harm, you have to raise an incident immediately after event.
Yes.
One of the most common tool which is using for an incident
Yeah, even I wanted
analysis.
to ask you, do what do we, have to tell to the nurses? Like, is this the structured way of sorting the RCA? RCA is root cause analysis. Yes. They should have a guideline to sort their RCA. Yes, over to you for little short, information about this guideline. Yeah.
This is, this is look like a fish, so often it called it as a fishbone diagram.
Yes.
The scientifically called as Ishikawa diagram.
Yes.
This is basically a pictorial representation of all factors which is influencing for one error. The
Yes.
most common factors it categorized into six types. It could be an equipment error, either process or people or materials or environment or management is not giving allocated resources or the system. So
Yes.
if one pictorial presentation is giving all the factors, so it can be jotted down, and each factor how much percentage which is influencing for that particular error. So to eliminate, this is a structural way of doing an RCA. This is the most widely used across the globe
Yes.
to identify each factor, how much percentage which is influencing further error.
Yes, so that proper RCA and kappa can be, drawn upon. Yes. Is near miss reporting online happening, or do we still have a long way to go? Sumani, what is your practice at your setup, or what do you think about this?
In many hospitals, especially in India and other developing countries, online near miss reporting systems are still limited. Most
Yes,
near misses are either not reported at all or recorded manually, either in the paper
yes,
forms or verbal communication. Even hospitals that have online system compliance is low because staff fear blame or punitive action. Near misses are seen as not important since no harm occurred. Reporting platforms are not user friendly or take too much of time.
yes,
Online,
yes,
yes. Online reporting system might be existing in tertiary hospitals or accredited driven hospitals where real time data is captured. However, we have long way to go. It's
yes,
not
I know.
uniform across every institute.
Yes. And yes, as you said, digital technology is again a different setup for which we all are actually waiting so that, it is going to fulfill ease our problem. Yes. Are training these nurses from right from the student period, is approach to improve this problem? I think you may also be having students who comes to, for the clinical exposure. Yes. What is your insight on the same?
I totally agree with your point where uh, safety culture should be imbibed in the nurses from their student period.
Yes.
This shapes attitude early. If nurses
Mm.
learn from the beginning the near miss, they value safety signal, not blame culture, and they carry the culture into their careers. This
Yes.
builds a safety mindset. Students should be trained to speak up when they are following unsafe, if they are instructed to follow unsafe practices, and they
Yes.
should not stay silent. They have to reduce, they have to be taught how to reduce this hierarchical barriers. I am just a student junior, I can't say anything. So bridging this gap is crucial, as we have to strengthen their competency and confidence by simulation trainings on medication errors, handovers, patient identification, build up the critical thinking. So
Yes.
not after the simulation training, we have to bridge this gap between theory and practices right from the first year at the bedside. And
Yes.
it's always we have to follow the global practice best practices, especially in other sectors like aviation, nuclear, and other western healthcare. Simulation is the right way of training where they will
Yes.
understand the scenarios. So healthcare education is now shifting towards human factors and safety science, not just clinical skills.
Yes, as rightly you said, nowadays we see a lot of nurses, they always present their cases and they learn through bedside even. Yes. So yeah, I think this topic was not enough for us to, be just finished within 15 or 20 minutes of time. Yes, we have come to the end of the discussion. And as, any problem which has to be ended, like what are the few preventive steps? Danishta, we want to give the awareness to the nurses. Yes, out there. Over to you.
No, the for a prevention, doing right thing and first time and every time. So as
Yeah.
every activity which they are doing, it has to be consciousness, mindfulness, following their protocols, making their checklist not as a tick list. Most of the
Checklist.
tick it, but if the patient gets admitted, all the tick tick boxes has to be tick. Their job is only for a ticking. So not making checklist as a tick list, promoting as a checklist only, and
Yes.
giving clear instructions when there is a handover or then the transitional care and innovation and technology when and encourage them to be as a innovation practices and a nursing day, either a patient safety day, doing some cultural activities based on patient safety and on-job training. Also most of the nurses comes from
Yes.
different setting, so on-job training and that system has to be taught them on a periodic basis, not in a single time one training has given. The overall throughout the year they have to be practiced, and there should be a near miss reporting system at every level. It could be a
Yes.
supervisor level or manager level or ground level, that has to be report. From reporting culture will learning culture will come. From learning
Yes.
culture will get flexible culture. Flexible culture where if one person if not there, immediately next supervisor or second keen will work on it. So such kind of practices and adherence to the well defined practices such as your standard operating procedure or guidelines. There is so many guidelines which are published by WHO or CDC or ARHQ. So there are so many institutes which are helping to promote the patient safety across the globe. So
Well,
with those we can
yes.
establish the safety and prevent the near miss.
Yes, as you rightly, focused on few preventive aspects for this problem. Yes, yes, I like to thank for your valuable, presence. I thank Danishta. I thank Sumani. I think yes, further we will have more networking towards the good cause. Yeah, I thank you.
Yeah.
Thank Sumani and
You-
Danishta.
Shanti Bhattacharya. And this session is dedicated for the millions of patients who either expired or suffered through serious harm or due to a patient safety incident.
Yes.
Please forgive us.
Yes.
Thank you for your presence and this opportunity.
Thank you so much.
Thank you so much. Thank you all for